Okay, good morning. I would like to welcome you to our debate. Our group consists of 5 members. I would like to start by introducing them and giving a little background. Our first team member is Carrie. Carrie is from California. For the past 3 years, Carrie has worked as a pediatric behavioral feeding therapist under a BCBA. She's providing home services, and she's going to graduate in May. Our second member is Madeline. Madeline is from Fishers. She has been working with individuals with disabilities for the past 6 years, lately working as an ABA therapist. Our third member is Rachel. Rachel is out in Arizona. She works as a center-based therapist and a home-based therapist. As a center-based therapist, she works with children ages 2 to 7. As a home-based therapist, she provides help for parents. Rachel's going to graduate in December. Our fourth member is Jayton. Jayton also lives out in California. He works as an executive at a technology company. When he graduates, he wants to open his own autism center. Our last member is myself. My name is Chris. I live in Indiana. I'm a special education teacher for an elementary school. I will graduate in December. Our topic for the debate is the right to exercise personal liberties versus the need for rehabilitation. Our debate format is a more informal debate with members providing points and counterpoints. And I would like to give you an overview of the things that we are going to discuss. Our first point is respecting personal liberties of individuals. Our counterpoint for that is habilitation allows realistic opportunity for a more meaningful life. Point 2 is medical model limitations versus neurodiversity movement. A counterpoint for that is medical conditions, physical limitations may lead to the need for habilitation. And our point 3 is habilitation inherently conflicts with personal freedoms. And the counterpoint for that is habilitation increases autonomy and therefore freedom. I'd like to introduce our first speaker. Here's Madeline discussing our first point, which is respecting personal liberties of individuals. Madeline?
Thank you, Chris. I'm just first going to talk about a few of our personal liberties. Some of these liberties include the freedom of speech, freedom of religion, and some other rights that are guaranteed by the Constitution. Some that I want to discuss in particular that are important for our individuals who have disabilities can be the right to decide where they live, the right to decide your medical care, your job, your right to marry, and just things like who you get to spend time with and what you do in your free time. The reason I discuss these is because of guardianship and why it is important that these individuals have these rights and they have the right to choose what they do. Guardianship is a legal proceeding that can strip people of their individual or multiple rights. A lot of the times, people who have disabilities are granted guardianship, or they have a guardian who are granted their guardianship and take care of everything that individual needs for their life. But with these major deprivations of these liberties, it's important to have a more rigorous process to grant guardianship. Right now, it is a super simple process, and it should take more than just signing it away. People who have disabilities should have the right to be able to choose these things, and with guardianship, they're stripped of all of these rights. You would hope that most times these guardians have the person's best interest at heart, but this is not always what happens. Something that is also important with guardianship and can be a major disadvantage is the longevity of the person. So if this guardian would happen to pass away, then this person who they are the guardian to can be left kind of behind without the chance to advocate for themselves because their guardian has passed. So something that is important to be, if you are a guardian, is to make sure that you know who would be taking care of your child, or it could be a brother or sister, whoever that you are the guardian to, because once you pass, which could really happen at any moment, which is so, like, honestly, obviously disappointing to think about, is that if you would become sick or even die, you would be leaving the person that you're caring for in a very bad spot. Another disadvantage of the guardianship is to be thinking about yourself as a guardian. It can be a lot of responsibility for one person. And when somebody agrees to become a guardian, they are taking on a lot of responsibility. They are basically in charge of a person's life. And so making sure that all of these right decisions are made can be a really big weight on your shoulders. And so for someone to be left there as a guardian, it can just be a huge undertaking. Something else that you should think about with guardianship is that court proceedings can be extremely expensive. They also can be very complicated. Sometimes the court can be overly involved with these private decisions as well. So something else to consider is that when guardianship is taking place, the court oversees these actions, and there's always a third party outside of the private family or private relationship that is reviewing the decisions a guardian may be making on behalf of the person who has the disability. And so this doesn't always happen, and honestly, it is not extremely common, but the fact that it is a possibility that this third party, who may not even know this person at all, has the option to make these decisions, I think is a huge thing to consider when going through the process of guardianship. And so it's just important that parents know their options, because frequently these parents are told that they have to get guardianship over a child with a disability once they are turning 18, if they want to be able to continue to help with education plans and their treatments, medical-wise or any behavior-wise. And so, but with this guardianship option, a lot of these people are living in this perpetual childhood. And so it's important to consider that these people have these rights to decide where they live, who they marry, what job they have, and that always doesn't happen, or it doesn't always happen when guardianship is in place. And so I think that Rachel is going to explain what some of the benefits with the habilitation opposed to what I have discussed. Thanks, Chris.
Okay. So I'm going to talk about habilitation as it allows realistic opportunity for a more meaningful life. So just a bit of background on habilitation. Habilitation really started, it came about because of a court proceeding, Wyatt v. Stickney. And in 1971, there was a federal court in Alabama that decided that individuals who were involuntarily committed to institutions because of mental illness or developmental disabilities have a constitutional right to treatment that affords them the opportunity to return to society. So in this court case, Wyatt, he was a 15-year-old juvenile delinquent. He had no mental illness. He was committed to an institution to, quote unquote, improve his behavior. Upon reductions in funds for mental health facilities, the institution he was committed to lost 100 staff members. Those staff members then filed a lawsuit, and the statement they made was that these patients would receive inadequate treatment with a reduced level of staff. They included Wyatt in the court proceeding and then eventually other patients from around the area. And the focus went off of these people losing their jobs and onto the rights of the individuals that were in these institutions. So this ruling created a minimum set of standards of care for rehabilitation for individuals with disabilities. And Judge Frank Johnson in this case stated, these people have a constitutional right to receive such individual treatment as will give them a realistic opportunity to be cured or to improve his or her mental condition. And he went on to compare these institutions to prisons, essentially, because there was no treatment involved and they weren't ever able to get the care they needed to attempt to re-enter society. So he defines habilitation in 1971 as the process by which the staff of the institution assists the resident to acquire and maintain those life skills which enable him to cope more effectively with the demands of his own person and of his environment, and to raise the level of physical, mental, and social efficiency. And this core proceeding created what we know now as the Wyatt standards. And these are standards of care. There's 3 fundamental conditions, and I'm really going to touch on the first one, which is a humane psychological and physical environment, which includes freedom from unnecessary medication, physical restraint and isolation, experimental research, unwanted treatment procedures, the guarantees of clothing, exercise, religion, all those personal liberties that Madeline just touched on. It also laid out a condition that we should have individualized treatment plans for people in institutions, and now that branches out to people that are under some of our care as we're becoming BCBAs. So habilitation now, we're focusing on teaching those functional life skills so that the individual can live their life more independently. And not that all of our clients are institutionalized, but they may need the guardianship to, while they're learning these skills, in order to enjoy their personal freedoms. Not all individuals have the repertoire of skills, and they don't understand the consequences of their behavior. So they may require teaching before being allowed to make their own choices. And this would where guardianship would come into play, is having a guardian to make those decisions while they're learning. It's similar to how we treat minors. So we treat minors as they're enabled to make competent decisions until a certain age or a certain maturity level. And by giving people too many personal freedoms before they're able to make appropriate decisions, we may actually hinder the acquisition of critical skills. So on the next slide, I have a chart of some self-advocacy and determination skills laid out by age. And these are just starting with ages 2 to 5. It's simple ways that you can teach and help habilitate a child to learn how to be their own individual. So something as simple as teaching a child to communicate with yes and no, offering choices of what the child wants to wear that day. And then as the child gets older, potentially including them in the IEP meetings if it's appropriate, if they're able to sit down and advocate for what they want to learn. And then as the child gets even older, teaching them to learn about their own personal freedoms and advocate for themselves, whether that be leading their own IEP meetings, assisting in writing their own long-term goals and transition plans, learning how to write accommodation letters for potential employers, and learning about their rights as they age through the Americans with Disabilities Act. So now, Madeline and I, though we debated this point, we also agree that there needs to be kind of a middle ground here, that so a person can engage in their personal freedoms, there needs to be some guidance and teaching. So Madeline's going to discuss a supported decision-making model, which can help with that.
Thanks, Rachel. I really appreciate your discussion of self-advocacy and learning these skills along the way for these individuals. And so I found an up-and-coming alternative model that is called the supported decision-making model. And it helps people who have disabilities have more access to their rights in decision-making. And so this model empowers individuals who have these disabilities or cognitive challenges, and it helps them by ensuring that they are the ultimate decision maker. But they are provided support from people who are in their support group, or people who would have been their potential guardian under guardianship, but instead are just supporting them through this decision-making model by helping them, by giving them the assistance and helping them make the decisions that they need to make for them to be a healthy, safe individual, but also not ultimately making the decision for them. So guiding these individuals to understand their options, understand responsibilities and consequences, and also understand really any information that is relevant to their decisions. And they also, through this model, can help communicate these decisions to the appropriate people. And so through this model, it really can help improve quality of life for people with disabilities, because they are feeling more empowered and more in tune with these basic rights that every person should have, and are ultimately the ones that are making the decision, even with some support from their support groups who are helping them during this model. So I think that Rachel and I can come to a common ground with this, and I was happy to be able to see this model and where people who have individual disabilities can be more empowered in their decisions.
Thanks, Rachel and Madeline. Great points. One of you guys mentioned effective treatment, but what happens when there are medical limitations that may or may not interfere with medical treatment or effective treatment? To debate point 2 is medical model limitations versus neurodiversity of movement, and Carrie's going to talk about that. Carrie?
Thanks, Chris. In this next section, I'm going to focus primarily on autism as it pertains to this topic, because that's the population that most of our group is quite familiar with, but I do think this information is applicable across various developmental levels and abilities. So I wanted to examine the effect of treatment of autism on self-determinism and the concept of neurodiversity. So the neurodiversity movement was initiated by individuals with autism who are self-advocates along with their families. And they suggest that autism is caused by biological factors and should therefore be celebrated as a natural part of human variation. Proponents of this movement reject the notion that normalization should be targeted simply for the sake of normalization. And so they promote subjective well-being and adaptive functioning versus strict normalization. So this kind of marks a distinct contrast with the medical model. The medical model tends to focus mostly on scale deficit and behavioral deviations from the social norms. And neurodiversity lends support to the notion that the use of therapeutic interventions that target behaviors that are harmless yet against social norms can be considered limiting to personal freedoms. So an example of this might be someone who makes limited eye contact, or someone who engages in hand flapping behaviors. These are relatively harmless behaviors, but they may serve as soothing or stimulatory. They may serve quite a function to the individual, but they are against typical norms. So in 2013, Kapp and colleagues examined awareness and attitudes towards neurodiversity, and their findings suggested that self-identification as autistic and awareness of neurodiversity did not support interventions that were targeted strictly at ameliorating behaviors. So those factors actually contributed to viewing autism as a positive identity and one that is not in need of a cure. So to expand on this point a little bit, I wanted to touch on the issue of adaptation. The Autistic Self-Advocacy Network calls for the recognition of autism as part of human diversity. And so they really have a strong call for society to create better adaptations for its citizens with autism versus people with autism being habilitated to conform to social norms. So, for example, instead of implementing a program to eliminate a self-soothing and harmless behavior, such as covering someone's ears, service providers should instead look at the environmental variables that could be creating an unbearable sensory experience to that particular client. And then in wrapping up this part of the issue, I just wanted to touch on the ethics codes. So I wanted to reference ethics codes 4.02 and 4.05. So these note that behavior analysts have a responsibility to make sure that behaviors targeted for change are described to and agreed upon by clients. So pushing interventions which are targeted at just conforming to social norms with that sole purpose, that would be, not only a violation of ethics, but it's also a violation of personal freedoms.
Great points, Carrie. But what about the individuals who say medical conditions, physical limitations may lead to the need for habilitation? Jatan?
Yeah, so the point that I would like to make is about medical condition as well as physical limitations and how they may limit a person's ability to do quite a few of activities. But before discussing this point further, I wanted to spend some time talking about what is freedom in the context here. So first of all, I would like to discuss the concept of freedom based on the research by Bosted and Hainish in 2016, as well as Hegel's Elements of Philosophy of Rights from 1821. So Bosted and Hainish in 2016 discussed the concept of freedom and the importance of context while defining the freedom. So Bosted and Hainish define freedom as opportunities for choice divided by individual facilitation. Bosted and Hainish described individual facilitation as physical and social environment adapted to individual needs. Most people with medical conditions or physical limitations that affect their movement, vision, hearing, cognitive abilities are limited in their ability to communicate. However, with the interventions, these skills can become functional. As such, we need to take the concept of freedom in the context of facilitation of freedom. Bosted and Hainish described that individual freedom increases with ordinary facilitation and also removal of situation-specific barriers or constraints that can replace contingent barriers with natural and ordinary conditions. So as described by both Bosted and Hainish in 2016, as well as Hegel's Elements of Philosophy of Rights from 1821, suggests that freedom has two components. One is independence, and the second one is interdependence. Because lives of people with disabilities can be oppressed or mistreated, lives of people with disabilities are characterized by unfreedom. Bosted and Hainish hence provide a concept of dependent freedom. And I think that concept of dependent freedom is very important in the discussion we're having today. They challenge that the concept of traditional definition of freedom as independence and bring the notion of interdependence. So people with disabilities, the dependence on facilitation and environment can be universal and can bring about more freedom. So one of my own arguments in support of this work is let's talk about like wearing glasses and how it improves an ability to read or see, and that provides inherently then the freedom as a result. So just as we rely on technology to help improve our ability of freedom, habilitation for individuals with disabilities can bring about freedom. Even if it's a dependent freedom. Owen and Simmons in 1993 discussed the point that many individuals with development disability may not perceive choice is available, and furthermore may not be even skilled at making the choices or indicating the preference. So these people may need to be taught how to make choices, and habilitation may provide such skills. So again, this first main point I wanted to make was about defining what freedom is and the concept of dependent freedom that is an important part of what we are debating today. And going to the point that Carrie was making about medical conditions and physical limitations, one of the things I wanted to share is some data that there is a marked disparity of health between individuals with development disability and the general population. So Irvin and et al. In 2014 highlight the point that individuals with development disability can more fully participate in communities when they are not constrained by poor health and can access necessary resources. So the chart here basically shows the data that more than 70% of individuals with disabilities have higher probability of having 2 or more chronic health conditions, which increases the complexity of integration with general population. Also, these individuals, another issue is that compared to non-learning disabled peers, adolescents with learning disabilities engage in higher level of risk behavior. So when we're thinking about the chronic illnesses as well as their other issues of behavioral issues, it's an important thing to keep in mind. So the point I want to talk about is compared to, so McNamara and Willoughby in 2010 described the risk-taking behavior that may include minor alcohol or drug use or delinquency, acts of aggression, sexual activities, etc. McNamara and Willoughby conducted the research on a population of 644 students across 25 high schools in Ontario, Canada. Trained research and staff administered the 23-page self-reported questionnaire about lifestyle choices. Significant between-group difference was noticed in the area of smoking, marijuana, delinquency. And so this study also showed that psychological factors played a role for such risk-taking behavior. While there are limitations of the study, including self-reporting, it highlights the point for the need of education and training for avoiding risk-taking behavior, which can be facilitated through habilitation. And then the last point I wanted to make here was that the primary and secondary healthcare services available to general population are not adequately prepared or trained for individuals with development disabilities. So Irvin et al. In 2014 discussed the historical aspect of medical model where individuals with development disabilities were looked from the lenses of the medical model than do today based on community-based model. As pointed out by them, while the institutionalization effort in past 30 years have encouraged our nation's medical establishments to address causes and treatment of individuals with disabilities, there's more progress that needs to be made in this area. So insufficiency and inadequacy of various treatment, as well as lack of sufficient training for staff, provides making it difficult to have adequate professionals to serve individuals with disabilities. And thereby there is limitations and just general population of providing the treatment that would be provided through habilitation. So again, I think both our points on the Carrie side and my side could be, again, brought together. There are some ethics principles that I would say coming here into place, one being the respecting autonomy and the other one being according dignity. Both are important. And as we discuss the pros and cons of medical model, we just need to keep in mind the context of freedom and then how the individuals with disability can benefit by having the habilitation.
Thanks, Chetan. Great points about freedom and habilitation. But what about when habilitation conflicts with personal freedom? Carrie?
Thanks, Chris. Yeah, next I wanted to kind of explore some of the problematic aspects of habilitation. First, in correlation to what I touched on earlier with the neurodiversity movement, we need to examine individual choice versus societal opinion within the context of habilitation. So freedom inherently implies choice. So I think it's necessary to touch on the acceptability of intervention or of habilitation from the clients or stakeholder clients who are receiving them. Ideally, habilitation should be focused on the long-term needs of an individual. Unfortunately, we know, in cases such as the Sunland Center, that's not always the case. And I just wanted to provide a quick little anecdotal quote from the Brownlow and Odell 2009 study in which an individual with autism, in reference to the methodology of ABA, was quoted to say, "ABA is a way to bring me completely into the social world, and I do not want to go." And so to address our ethics code in relation to the first part of this section, I did want to reference code 2.15, which states that the discontinuation of services is necessary if service is deemed ineffective or upon client request. So we do need to remember that should an intervention be ineffective or unacceptable to clients, such as in the events I was talking on earlier, where harmless behaviors are being targeted simply for the sake of normalization, these interventions or habilitation would need to be terminated. So what can happen if habilitation is not discontinued when it begins to violate ethical obligations or personal freedoms? So in 2009, Brownlow and Odell explored the notion that neurotypical staff may unintentionally bring indirect discrimination against clients with disabilities. So as described by the government equality offices in 2010, indirect discrimination occurs when there's a common practice that applies to everyone, but it can place individuals with disabilities at a particular disadvantage. So to expand on this point a little bit, habilitation or intervention practices can not only be disadvantageous, but if they're brought one step further, insufficient respect from neurotypical staff for low-functioning individuals has the potential to lead to discriminatory practices. And I think this touches a little bit on what Jatan just mentioned in terms of having well-trained and qualified staff. But Hughes and colleagues in 2011 conducted a comprehensive literature review, and they concluded that lifetime prevalence of interpersonal violence against adult women and men with disabilities actually occurs at disproportionate and elevated rates compared to non-disabled adults. And I just wanted to share this next slide here. This is from Sullivan and Knutson in year 2000, and they explored the relation between maltreatment and disabilities in populations of children. And their study depicted a 9% prevalence rate of maltreatment of children without disabilities compared to a 31% prevalence rate for disabled children. So you'll see in this chart that the highest level of maltreatment occurred with children with behavior disorders. So given the disconnect between the goals of service providers and versus personal freedoms of individuals with disabilities that can often occur, and considering the elevated probability of maltreatment and discrimination against individuals with disabilities, the methods and service delivery of habilitation really needs to be carefully examined to monitored to ensure that personal freedoms are not being jeopardized within treatment or within habilitation.
Thanks, Carrie. Great points. You made a comment about focusing on long-term needs of individuals, but what about the people who say, you know, if they get habilitation, the habilitation increases autonomy and therefore it increases their freedom? Jatan?
Exactly. So I think Carrie made great points about the fact that respecting personal freedom is an important aspect of this whole debate we're having. There are 2 points I want to make. One is the fact that all the federal laws and legislation that is out there, the laws that are out there to protect and then help the individuals with disability, and then habilitation type services that actually help them get there. And then a second point, which is the fact that increasing autonomy increases participation and then also reduces the problematic behavior. So in fact, it can help with the freedom that we're talking about earlier. So the first point, the federal legislation includes Development Disability Act and Bill of Rights Act of 1979 and Rehabilitation Act of 1973. And when we look at what's covered here, one of the research by Kindred et al. In 1976 that they discussed the point that people with development disability deserve the equality of protection and rights under law, respect to other members of the community, civil liberty, and age-appropriate activities as it pertains to lifestyle. So just the way people come from work and turn a TV on, go to bed when they want, Owen and Simmons in 1993 suggested that individuals with disabilities should have similar rights to have that freedom. So, and also White and Stickney case, which is the Stickney case in 1971 that Rachel talked earlier about, led to the federal court determining the citizens with mental retardation having right to receive the habilitation, as well as giving them realistic opportunity to lead a more useful and meaningful life to return to the society. So this case has led to a having minimal standard of care. Also, the U.S. Code 15009, which is the rights of individuals with development disabilities, it covered this aspect as well. And Congress also made the following ruling and to respect the rights of individuals with development disability. There are 2 aspects to it. One is individuals with this development disability have a right to appropriate treatment and services and habilitation. And the second one is the treatment, service, and habilitation for an individual with disability should be designed to maximize the potential in the setting to allow personal liberty. So when you think about this aspect, and given that the laws also are supporting that, then it comes down to the second point that I want to make is that the fact that increasing the autonomy increases the participation. So Owen and Simmons in 1993 discussed the concept of positive impact of habilitation by increased participation with decrease in problematic behavior. Guess et al. In 1985 suggested that positive outcomes associated with personal choices that are considered important include increased self-esteem and personal dignity. Owen and Simmons suggest that policies and practitioners who allow clients to continue choose to do nothing for extended hours within a day, or fail to meet the long-term needs of an individual. Keeping the long-term needs of a client in mind, habilitation program can lead to ability to make choices for individuals with disability. Jeannie Wilcox, who's a vice president of an organization called ASHA, in 2011 discussed the idea of habilitation is not about waiting for an individual to fail to develop essential skills, but it is focused on making sure that at-risk individuals develop foundational skills to enable acquisition of more complex foundational skills. So keeping this in mind, again, the point isn't as much as debating whether personal freedom is important or not, but it's more about how do you actually acquire that freedom, and habilitation has a point of helping acquiring that freedom. So while it may, Karen, my point may seem more like opposing, it's really, we can come to a middle ground where we talk about the importance of freedom, but then how to acquire that freedom with the use of habilitation.
Thanks, Jatan. Thanks, guys, for your insight and information today. We're going to recap by addressing some of the questions that have come in during our presentation. We have 3 questions that we want to address. The first one is, do personal liberties differ when working with children versus when working with adults? I think personal liberties will differ when working with children versus adults. When kids are smaller, you can give them the small choices on what to wear to school or what to eat. And as the kids get older, you can offer more choices and teach children the civil liberties that they can that they have and that they will have when they get older. But when we're working with children for treatment, the parents tend to be the one driving the treatment and making those decisions. As parents get more frustrated and more desperate, they are more willing to forgo their civil liberties in order to get what they would consider a more normal life. For example, I work in an elementary school as a special education teacher. I work with children with emotional disabilities. My services range from a self-contained service, which is a highly supervised service, to just giving support in the general ed classroom. No parent wants a child separated from peers, and they don't want them to miss out on anything that's going on in the general education classroom. But I think also that the more desperate the parents get for help, then the more willing they are to have these kids separated, and the more times that they have requested that the kids get separated. Because at the time, the parents feel that the separation would be more beneficial for the child versus being in the general education classroom and continuing to misbehave. So yes, when working with kids versus working with adults, personal civil liberties would be different. Our second question is, how can choices be made available to individuals who have limited resources? For example, what if someone has limited finances due to Medicaid funding? Rachel?
So the first thing I want to say about this is what Carrie mentioned, that not all clients want habilitation and want to be sort of mainstreamed into our typical ways of doing things. But for those clients that do, and for those parents and guardians that do want that for their child, the first thing is education on what those rights are. So the IDEA Act, the Individuals with Disabilities Education Act, covers children up to 21 years old, and this lays out their rights for education and habilitation for those ages. So educating yourself on what rights are available through that, as well as the ADA, the Americans with Disabilities Act. So as they become older adults, what rights do they have? And as Jatan mentioned, in the past 30 years, there's been an effort to increase habilitative treatment, but there still needs to be progress. So clients are going to have to advocate for themselves and which habilitation treatments they want. If they want to learn how to vote, how to have an apartment and care for themselves, they really need to be educated on what their right is and how to advocate for that in their services. So how to appropriate the services they do have and the funding they do have to get what they want out of that funding. Another thing is what I mentioned earlier in my point in the debate is the self-advocacy and determination skills Some of these are easy ways that parents and guardians and caregivers can help promote those self-advocacy skills for their child or the client. So some of those are encouraging the communication of the preferences, what you want at school, you want to eat breakfast, teaching child then to make good choices of what are healthy food, what are good activities to engage in, maybe first doing your homework and then engaging in your free time activity. Teaching a child to manage their anxiety and communicate anger and those sorts of emotions so that they're able to in the future. Teaching a child to order their own meals, letting them be part of their IEP, letting them plan weekend activities. These are all easy things that parents can do that will foster self-advocacy so that when it comes time, they have more of those skills. And if they have limited finances, some of those foundational choice-making skills are already in place, and then they can appropriate the funds to where they really need them for their rehabilitation goals.
Awesome, Rachel. I'm going to go ahead and touch on our last question, which was, do you have any personal experiences related to this topic that you would like to share? And this actually comes at a good time because in my personal experience, I kind of touch on points that both Chris and Rachel discussed in their questions. Particularly, my experience relate a lot to what Chris discussed, where the difference is working with children versus adults. And so during my full-time job, I am an ABA therapist, and I work with individuals who are like 3, 4, 5, 6 years old, very young kids. And so, and then during a part-time job, I'm a respite care provider, and I work with an individual who is 24 years old. And so it really is interesting to look at, in particular, these ethics codes that discuss consent that is needed by the client. And so when I'm working with these 3 and 4 year olds, codes that are like 4.02 involving clients in planning and consent with behavior change programs, and then also 4.04 approving behavior change programs. It's really interesting to read these and apply them to my clients, because my 3 and 4 year old clients are never involved in these planning procedures. It's always their parents, where my 24-year-old client, while the services I'm providing to her aren't behavior change programs, they're programs that are similar to what Rachel discussed with self-advocacy, that she is extremely involved in. And so when we have these planning meetings for my behavioral clients, the clients are not involved, but with Alex, my 24-year-old client, she's extremely involved. And so with her, we are discussing these self-advocacy skills and seeing what the priorities of, like, for her are. So, you know, obviously we want to discuss every skill that she'll need, but right now we're really honing in on health, because for her, that is a priority right now. And so it's really exciting to see her to be able to advocate for herself in these meetings, because she is older and has the ability to do so. And so with the help of her mom, she can advocate for herself. And so right now we are working on health. And so we do things like go to the gym, plan out meals, things like that. And so the differences between kids and adults can be very different. And so to wrap things up, I just want to thank all my group members for an amazing job and working with each other this past semester. It's been great. And I just want to thank you all for watching. And I hope that you guys can have a better idea of what we have discussed today and the pros and cons throughout. So thank you.